All right, on this episode, we're going to talk about STEMI Mimickers. If you clicked on this video, then I assume you've had a patient in the past, just like me, where you did a 12 lead, you saw ST elevation, you activated cath, whisked the patient down to PCI, only then to find out that the patient wasn't actually having a legitimate STEMI. And so hopefully after watching this, we'll be a little bit better at being able to determine when we actually have an activatable STEMI versus a mimicker. So I made up these terms, type 1 and type 2. This is just how my brain differentiates. Because I think it's important to note that there are pathological conditions that will cause non-discernible ECG patterns to a true STEMI. And these are things like coronary vasospasms, Takotsubo's cardiomyopathy, etc. Type 1, though, is kind of what I wanted to focus on today, because type 1, to me, these are things where, yes, there's ST elevation, but there are other parts of the ECG, whether that be the shape of the ST segment or the height of the T wave, or a couple other things we're going to talk about, which should key you in that this is not a legitimate STEMI and does not warrant activation. So those are things like what you see listed on your screen, things like LVH, pericarditis, benign early repole, left bundles. All these things have ST elevation or can have ST elevation present in their EKG, but doesn't necessarily denote that the patient's having a STEMI. And so we're going to kind of parse through each one of those, focus on the EKGs, learn what's normal with them so that you can determine abnormalities and be able to identify when you need to activate and when not to. The type 2 mimickers you see listed on there, these are ones where you need to focus more on your physical exam. If you work in hospital, lab values can help in certain cases. But these are patients where the disease process itself is going to cause identical presentations often to what you see in a legitimate STEMI. And a good example is the coronary vasospasms. In that disease process, one of your major coronary vessels spasms closed and disrupts blood flow to the myocardium, just like you would see if it was a blood clot. So the EKG can't tell a difference between whether it's a blood clot or coronary vessel that is just spasm shut, either due to stress or stimulant ingestion. The ECG presentation is going to be identical because from a pathological sense or from a physical sense, the myocardium is just not getting blood flow, whether it's a blood clot or coronary vasospasm or an aneurysm. Your aneurysms can back dissect through a coronary vessel and disrupt blood flow in the same way. And so whether your right coronary vessel is spasm shut, whether it's a blood clot, whether it's a bleed, from an EKG standpoint, it's going to be identical. And so this is where the ECG is not going to help you. It's not specific of enough of a diagnostic. You're going to have to rely on your physical exam lab values, etc. And just a note too, on this list, some things that people don't necessarily think about, but even things like profound hypoxia, shock, early after cardiac arrest, in profound states of tachycardia, which is what demand ischemia is, all those things cause some form of perfusion mismatch and myocardial ischemia that can progress to infarction and mimic STEMI, even when there's actually no occlusion present. So kind of with me, when I'm looking at an EKG, some things that go through my head when I see ST elevation to try to determine, hey, are we going to activate or not? Right off the bat, if I have severe tachycardia, I'm talking heart rates greater than 150, profound hypoxia, or the patient was recently in cardiac arrest, I'm always going to be a little hesitant to activate STEMI, especially off of a single ECG. And that's because all three of those things can cause non-discernible ECG changes that make it very difficult. It's a confounder that must be controlled. We need to control if their heart rate's 180 beats per minute, maybe they're in SVT, you've got to convert them out of SVT before you can make that kind of call. If their oxygen saturation is 50%, we need to correct that. Honestly, if their oxygen concentration is legitimately, or I'm sorry, oxygen percentage is legitimately 50%, and not just your pulse ox isn't picking up because they're hypotensive and in profound shock. But if they're legitimately hypoxemic, I'd be questioning whether I have a STEMI anyways, because that would be a rare presentation, right? To have an acute MI where they're profoundly hypoxic. And I'm always hesitant in the first few minutes after cardiac arrest with any post-arrest ECG. In fact, typically for me, I usually wait several minutes before I get my first ECG post-arrest. There's other things I need to be doing. That's a high-risk chance for rearrest. I'm going to be focusing much more on hemodynamics, perfusion, getting the patient situated and assessed before I'm thinking about an ECG. And I've had some people argue with me and be like, "Oh man, if you have a cardiac arrest and you get post-ROSC, we gotta know, are we going to activate cath or not?" Well, if your patient was in VFib arrest and you got ROSC, you should probably already be thinking about activating. I forget this specific number, but it was around 1 out of 3 VFib arrests, irrespective of their post-arrest ECG, were positive for a coronary occlusion. So if you're playing the odds, your pretest probability with a VFib arrest is that it's a STEMI anyways, and you should be presuming that and going to a cath lab from scene if you're working pre-hospital, in my opinion. A couple other things I look at. This is a big one. ST shape. Is it convex? Is it concave? Smiley face, frowny face. Most of the mimickers will that are discernible, so your type 1s will present with concave or smiley face ST elevation. I have some examples I'll show you. Convex ST shapes are one of the hallmarks of an early MI. In fact, that's an early warning sign. Oftentimes, before you develop ST elevation, you'll start to get the frowny face, convex ST shape. Overall ST height is another one. Most of your mimickers are not going to produce massive amounts of ST elevation. And what do we mean by that? If your ST elevation is greater than 50% the overall magnitude of the QRS, that's a pretty good indicator in of itself that you're probably dealing with a myocardial infarction or a true STEMI. Things like pericarditis, benign early repol, even the left bundles and ventricular pacers, none of them typically produce ST elevation to that degree, whether it's discordant or concordant elevation. T-wave height's another one. STEMIs make big T-waves, so if you have little T-waves, that starts to make me think maybe, I'll take a second look at it. And the same thing with Osborne waves. Osborne waves are these little upside down J fishhook looking waves after your QRS complex. And if you see those present, that really gives me pause before I'm going to activate that I'm not dealing with a mimicker like BER or pericarditis. So let's just kind of start working through some of these. So LVH is a big one. It's probably one of the most common ones I would say that I see people sending me EKGs going, oh, I think this might be a STEMI. So LVH is just left ventricular hypertrophy. That's a big left ventricle, and that's gonna produce some very predictable ECG patterns that you can look for. First off, one thing to think about is what causes LVH in the first place, right? So that's going to be anything that's a high afterload state, anything that causes the left ventricle to work hard. So that's going to be things like chronic uncontrolled hypertension, stimulant use. A lot of patients I see that are chronic abusers of methamphetamine, even earlier on in life, in their 20s or 30s, can develop a significant enlargement of the left ventricle. The QRS can be wide or narrow. It's typically wide, but it can be narrow, especially if you get that younger stimulant toxidrome type stimulant user. Can have a leftward axis, doesn't have to, but that makes sense, right? Big left ventricle, it's going to pull the electricity to the left, and you're going to have a left axis. If you don't remember how to look at axis deviation, I do have a video on that you can watch too. T-wave inversion. So really something else to understand about all ECGs in general is anytime you have an abnormal depolarization of the ventricle. So those are going to be things like any wide QRS especially, your T-waves will flip. And so you'll often have what we call discordant T-waves, where your QRS is on one side of the isoelectric line, your T-waves on the other one. So in LVH's case, you have notable T-wave inversion in the lateral leads that often is accompanied by some ST depression. But the thing that throws people with LVH is that your standard LVH patient is almost always going to meet criteria for an anteroseptal STEMI, especially in the early precordials, V1 through V3, because you're going to have a downward QRS complex and your T-waves are often upright. And because you have that discordant relationship between the QRS and the T-wave, it's very common in all ECG patterns where you have discordance present that the ST segment will often deviate away from the isoelectric line with the T-wave. That's very common. So in a downward QRS and an upward T-wave, you're going to have some ST elevation. And that's what you see in LVH. Your QRSs are almost always down, V1, V2, V3. Your T-waves are up. And so you have some ST elevation present in V1 and V2 especially, and sometimes down to V3. Let's look at some examples. So you can see here, if I'm scanning this, let's say this patient has chest pain, they come in, they do their 12 lead, we look at this ECG here, and some things jump out at me. First off, my QRS complexes are really big, especially in your precordial leads. So that should key you in right away. Like, I don't know, it's not that a STEMI can't have big QRSs, but definitely can for sure. But you want to look at this for a second and go, okay, what are we dealing with here? So if I look at where the energy is going in the heart, I've got a left axis. I can tell that because AVL is the most positively deflected QRS in the hexaxial leads. I screen this for ischemic changes and I go, oh man, I see some ST depression at V5, V6. I look up at V1 and V2, especially in V2 and actually V3. If I look close, I see I have about 2 or 3 millimeters of ST elevation, which might make you think, hey, I've got a STEMI. But again, my QRS is wide, the QRS is down, the ST segment is up, and it's going with the T wave. That is something that would make me think that that's appropriate, because that's what I would expect to see in this case. Just like in V6's case, the QRS is up, the T wave is down, and the ST segment's going with it. In a wide QRS with a discordant pattern like that, that's what you should predict. That's kind of that's the foundation of Scarbosa criteria as well, which is the criteria we use to differentiate STEMI in the presence of things like LVH, left bundles, pacers. I have a video on that as well if you want to review that. So here's another example. Again, big giant QRS complexes. I see some ST elevation in V1, V2. Nothing crazy, but what I see that's really concerning if I'm scanning this for ischemia is I see some pretty significant ST depression, V4, V5, V6, and then extending out into 1 and maybe even a little bit in AVL. And so that would catch my eye, right? That would be, at least I would maybe think, oh, this is ischemic change, this is an ischemic pattern. But when you're looking at this patient's ECG, you can tell pretty clearly that he or she has the hallmark of left ventricular hypertrophy. Their QRS complexes are massive, which makes sense because they have a big left ventricle, so they're going to be producing more energy. And they're down in V1 and up in V6, which is classic. You have the discordant T waves. If you look at your EKG, your T waves in almost every lead are on the opposite side of the QRS, and you can see that the ST segment is going with the T wave. Again, that's what I would expect. If I was scanning this for a STEMI, what I would really be looking for right off the bat is, do I see ST changes that go with the QRS complex? So rather than seeing a ST elevation in V1 and V2, what would actually be concerning in those leads is if I saw ST depression because the QRSs are down, and that wouldn't make any sense. The only thing that could cause that type of ST change, where it goes with the QRS complex, is going to be that acute MI patient. The ST segment going with the T wave, when they're discordant like that, is what we call appropriate discordance, where the ST segment's moving with the T wave to an appropriate amount. And another example here, again, what do we see? Big QRS complexes, giant magnitude. You can see some pretty prominent ST elevation in V1, V2, and V3. But again, if you compare that to the overall size of the QRS complex, it is not clinically significant. For it to be significant, it would need to, again, the ST segment either need to be going with the QRS complex, or if it was going with the T wave, but to an excessive amount, which would be somewhere around 25% the overall magnitude of the QRS complex, then we would also say that's concerning. So yes, the T wave can and should pull the ST segment when you have an abnormal depolarization such as this, but there is a limit to it. And so again, the bigger the QRS complex, the more that limit would be. And we're not even close to that 25% mark with that amount of ST elevation. It's hard to even measure how big those QRS complexes are because they bleed into the subsequent leads below or above them. So again, that's a clear hallmark of a enlarged left ventricle or some sort of hypertrophy. Bundles are another one, very similar in presentation to an LVH. They do have to be wide to have a true complete left bundle branch block. The QRSs can be big or small. That depends a little bit on the pre-existing history, but it's kind of the same deal as the LVH. You have discordant T waves. Anywhere where the QRS is pointed downward and the T wave is pointed upward, you're going to have some ST elevation built in. That's normal. That's called appropriate discordance, so long as that discordant elevation does not exceed 25% the overall magnitude of the QRS. And again, everything that I'm talking about there is detailed out in your Scarbosa criteria, which I have in a different video. A couple more things with at left bundles, they tend to have a left axis as well, based on where the electricity gets diverted in the block. The left ventricle becomes excited in a left bundle because it's an abnormal firing, which of course produces more energy, draws your energy to the left, and that's why you end up with a left axis. Otherwise, in criteria, they can be very similar in presentation to LVH. So you can look here, if I'm scanning this, oh, I see some ST elevation in V1, V2, V3, all the way out into V4. But when I'm looking at it, scanning for that acute MI, some ways to tell the difference. The QRS is down in those leads, the T wave is up. So that's what I would expect because these are discordant T waves. They flipped because of the abnormal depolarization, because in this case, your left bundle branch has been completely blocked. And so your normal conductive pathways aren't working appropriately. And so this is what I would expect. This is a normal left bundle. The patient has a left axis, just about. Also something that I would predict when I look for the ST elevation, I see it in V1, V2, V3, and V4. So I need to measure it because it's going with the T wave. If any part of it was greater than 25% the depth of the QRS, then I would be concerned. Or if the ST segment was going with the QRS complex, I would also be concerned. So if in V1, V2, V3, or V4 I saw some ST depression, that would be concerning. Or if that ST elevation was significantly greater, definitely more than 5 millimeters, then I would have to take a second look. And of course, all of this is predicated on the assumption that your patient presents with some signs and symptoms associated with acute coronary syndrome. I teach all my students, no matter what the EKG shows you, you have to have a clinical presentation to match. I'm not saying the patient has to have chest pain, because of course acute MIs can have a very diverse presentation, but your heart can't be dying, the patient's heart can't be dying and then be completely and utterly asymptomatic. There's going to be something to it. So, if you did a 12 lead on a stub toe and you see some ST elevation, doesn't necessarily mean the patient's having a STEMI. That's another example here. You can see kind of a similar pattern. Don't quite have the left axis, but you can see it is moving somewhat to the left. You've got your classic left bundle pattern. It's down in V1, up in V6. You got the notching present, the M pattern in V6. Your T waves are discordant, and you see some ST elevation and depression. However, it's going with the T wave, which is what we would expect. We measure it out always just to make sure that it's not excessively discordant, which it's not here. So this is an example of where I would actually have a problem. So this is another left bundle, and if you look at what's circled there, your QRS is up and the ST segment is going with it. Another abnormality is the fact that the T wave is going with the QRS. So you have what we call pseudo-normalization. In a wide QRS, you would expect your T waves to be discordant. So in the case of AVL here, you can see your QRS is up, your ST segment's up, and your T wave's up, and that shouldn't be the case. So this would be an example of what we call Scarbosa A criteria being positive in a left bundle. So this patient, this ST elevation is clinically significant and is predictive of an acute MI. If you, in this very same ECG, if you look over to V2, you can see ST elevation, but that ST elevation is benign. It's normal. It's what I'd expect because the QRS is down, the T wave's up, you have discordance, and the ST segment's going with it. This is another positive finding. So if I look at this is left bundle. Okay, so I see some ST elevation in V1, V2, and that's normal. QRS is down, T wave's up, ST segment's going with T wave. That's what I expect because it's appropriately discordant. I measure that ST elevation. It's not greater than 25% depth QRS, no big deal. But if I go just one or two leads down, so let's actually skip to V4 for a second. I look at V4. I'm starting to get a little worried there because yeah, my QRS is down. Yeah, my T wave's up. Yeah, the ST segment's going with the T wave, but that ST elevation is almost as much as the QRS is deep, so it's way more than the 25% that's allowed. So that would be what we would call excessively discordant. If I go one more lead down and look at V5, I can see my QRS is up and my ST segment's up. Well, that doesn't make any sense. In fact, my T wave is up too. Doesn't make sense for a left bundle. I would expect them to be discordant. So this is an example of that pseudo-normalization. If I scan over to leads 3 and AVF, and you can see again, kind of lead 3 doesn't look great, but if you look at AVF for a second, your QRS is up. Oh, but what's your ST segment doing? It's up too, and your T wave's up. And that doesn't make sense in a left bundle. You would expect to see discordance, and that you would see, if you see any ST deviations, you would expect it to go with the T wave. And instead, we're seeing the opposite. We're seeing the ST segment go with the QRS. So that makes it positive. So this would be an example of Scarbosa C criteria in lead V4, what we would call excessive discordance, and then Scarbosa A criteria and lead in the inferior leads 3 in AVF. Pacer is going to be in the same line. Now, one thing to denote is it an atrial versus a ventricular pacer? Because that does make a difference. Ventricular pacers are going to have elicit a wide QRS, and thus they're going to be the same rules that I've just been talking about with LVH and left bundles, looking at that relationship between the ST segment and the T wave. If it's an atrial pacer, that should elicit a normal ventricular contraction, and you would use standard STEMI criteria to look for it. So if you have an atrial pacer rhythm with ST elevation, then that patient's most likely having an acute MI, especially clinical presentation to boot. So we look here, we got a standard ventricular pacer. I've got some ST elevation in V1, V2, V3. You guys are hopefully catching the drift here. QRS is down, T wave's up, ST segment's going with it, not going with it more than 25% of the depth of the QRS. I'm not worried about it. I'm moving on. That's just a normal pacer. Here I see 2 notches. This is an atrioventricular pacer. Since we are artificially stimulating the ventricle, you're getting a abnormal depolarization, so you're getting a wide QRS, and so you got to use those same rules. I see ST elevation in V1, V2, V3, but the QRS is down, the T wave's up. It's no big deal. It's not greater than 25% the depth of the QRS, so this is what I would expect to see. Now take a look at this one. Practice it yourself. Maybe pause the video if you want. Give yourself a second to look at it. Look at that EKG. We see the pacer spikes. We see it's a ventricular pace rhythm. It's wide. And so we use that rule. We're looking at the relationship between the ST segment and the T wave. Which way is it going? If you scan this and anywhere on this you see the ST segment going with the QRS instead of the T wave, that's a problem. And so if I look at this one, if I look at V2, V3, V4, V5, my QRSs are all pointed downwards. Some of them are biphasic, but if you look at it, they're overall negative, so that's the same thing. And so they're all pointed down, and the ST segment is going with it, and so that is a problem. That's Scarbosa B criteria present in a ventricular pacer in the anterior leads, V2, V3, V4, V5. You see some ST elevation in lead 3 and AVF, but that's normal because the QRS is down, the T wave is up, and the ST segment's going with it. And it's not going with it excessively, meaning it's not going with it greater than 25% the depth of that QRS complex. So that would be an acute MI overlaid on a ventricular pacer rhythm. No, you cannot just circle ventricular pacer on your diagnosis and move on with your life. You do need to screen it for an acute MI. All right, let's change pace a little bit. So let's talk about some that are narrow, that have ST elevation in it, but end up also not being a STEMI. And so pericarditis is one of the famous mimickers. Okay, so this is a typically viral infection of the pericardial, and typically presents with diffuse ST elevation. The magnitude is typically highest in the anterolateral region. But the keynote thing with this to help with pericarditis, besides the clinical presentation, of course, the patient having positional chest pain, recent history of viral illness, ruling that kind of stuff out. Looking at this, you're going to see that the ST elevation is going to typically be diffuse. It's going to be concave, or what we call smiley face. And the ST elevation rarely exceeds 33% the QRS height. So it rarely exceeds a third the overall height of the QRS complex, and definitely rarely 50%. There's a couple other things that you can see. It's debatable, but some people kind of go back and forth about whether Osborne waves can be present. I have an example with them present. You also have PR depression that can be present, and you can have ST depression in AVR. So here's an example. Here we look at it. We see ST elevation in V3, V4, V5, V6, lead 1, lead AVL. It looks like you have ST elevation in lead 2, but you don't. You actually just have PR depression, so it's an optical illusion. But again, diffuse ST elevation doesn't really present with a classic pattern. Not a classic inferior, not a classic anterior, not a classic lateral or posterior. So could maybe be mistaken as like an extensive anterior wall MI, but again, so some key differences. A, look at the ST shape. It's concave, it's smiley face. We also see some Osborne waves. We see the fishhook pattern in V4, that little notch that occurs between the QRS and the T wave. And also too, the T waves aren't very big. Again, with acute MIs, you typically see really big T waves. So oftentimes the T waves in an MI can reach or exceed the overall height of the QRS complex. There's an example of what an Osborne wave looks like there. So that notching, upside down, fishhook, whatever you want to call it, pattern often coincides with that smiley face, upward concave ST elevation. Another example there, we see ST elevation, diffuse, pretty much across all the anterolateral region. But it's smiley face. Your T waves are a little bit bigger in some leads. Definitely would reach hyperacute definition, especially in like leads 1 and in an AVL. But again, ST elevation is smiley face. You see the notching pattern that's most prominent in V4, which is the Osborne wave. This patient is another example of pericarditis. Benign early repole is very similar. Benign early repole is more likely to produce bigger T waves. So the ST elevation to T wave ratio is smaller or greater, depending on how you want to look at it. In BER, there's a bigger difference between the T wave height and the ST elevation. But otherwise, they're very similar. They have diffuse, concave ST elevation in the anterolateral leads. They very often have the Osborne wave present. There's a very close correlation between Osborne waves and benign early repole. And benign early repole is not static. Some people think that you see the same ECG all the time, but their ST elevation can actually be dynamic and can change with autonomic tone, shock, excitement, etc. So if you have a patient with BER who syncopizes, that catecholamine surge that occurs during syncope could absolutely exaggerate their underlying ST elevation. It can make the differential very difficult. I actually had a case of that myself, where the patient experienced syncope, bradycardia, and had pretty significant ST elevation in the anterior lateral leads, but was simply just a classic syncope. Cath was negative, and the patient just had benign early repole. No wall motion abnormality on echo, normal EF, etc. So there's an example. Like I said, very similar to pericarditis. You see the diffuse concave ST elevation, the smiley face, most prominent in the anterolateral leads with a notching pattern present, indicating a STEMI mimicker, in this case, benign early repolarization. And another example. So again, looking at the anterolateral leads, you see ST elevation, not a lot, but you see that Osborne wave present, very noticeable in V5, and a little bit in V6 and V4. Again, not a STEMI, just some ST elevation. Hyperkalemia is a difficult one. I kind of sometimes lump it into both categories because it can produce some findings that are pretty hard to differentiate between the two. And I always say, especially if you work in hospital, this is very easy. Or if you have access to point of care lab testing, the easiest way to differentiate is to literally just measure their potassium. If their potassium is 9, you probably need to fix that before we just jump straight to the STEMI activation. Not that you can't have both. Nothing is impossible, but definitely would give me pause. Classically, there are some differences. I don't think that they're always that obvious to tell, but hyperacute T waves, typically in the acute MI, the T waves become very wide, symmetric and big, whereas in hyperkalemic, they're more likely to be narrow, sharp in morphology. Again, not an absolute. In severe cases, you end up with a widening of the QRS, which can actually manifest with some ST elevation. However, that ST elevation typically doesn't fit one of the classic patterns, whether it's inferior, anterior, etc. So here's an example here. Actually, you can see in lead 3, I've got, if I'm scanning it for acute MI, I see Q waves, I see that convex ST shape with some ST elevation. I even have some what appears to be reciprocal depression in AVL. So you might be thinking inferior. However, this patient's potassium was like 8.1 or something like that. And the ECG normalized after we gave treatment to the patient. So again, probably one of the easiest things besides just using the ECG is also the patient presentation, right? Hyperkalemic patients rarely are gonna, the symptoms for hyperkalemia and causes of hyperkalemia are going to rarely coincide with the ACS patient. Again, nothing is impossible, but this is one we're using physical exam and laboratory values may be your best bet to help differentiate. And another example there. So again, we have ST elevation and some ST depression, but you can see it produced this wide, bizarre looking ECG with profound discordant T waves that are very sharp in appearance. So could it be an MIE? Maybe, but definitely doesn't have a classic STEMI pattern, and this should give you pause. This is severe hyperkalemia. In this case, you're actually starting to get the sine wave pattern. You can see that really prominently in AVR. This patient, if presenting in any sort of shock state, your emergent therapy for this patient would be a bolus of calcium chloride to stabilize the myocardium, because this is a very irritated and unstable myocardium. You would do that emergently to correct this issue before moving on to other hyperkalemic therapeutics like insulin and albuterol. Let's do a couple practice here, just see how you do. So take a look at that one and see, do you think that's a STEMI or not? You can pause it for a second so you get a chance to look at it. Scanning it, we see a wide QRS, we see some ST elevation in V1, V2, V3, or I'm sorry, not in V3, but the QRS is wide, the ST segment is going with the T wave, and it's not going greater than 25%. So this is just a normal left bundle. Okay, take a look at this one, pause it if you need, so you can really scan it. Looking at those ST segments, I see the pacer spikes followed by a wide QRS, so this is a ventricular pace rhythm. I'm scanning it, I'm looking, I see QRS complexes that are pointed downwards in V2, V3, V4, and V5. The ST segment is going with the QRS. Well, that doesn't make any sense. That's not what we want. The ST segment should be going with the T wave or should be isoelectric. And so since I have ST depression in the presence of a downward QRS in a wide V-paced rhythm, that is going to be Scarbosa B criteria. This is the actual STEMI. Can't call it a STEMI because there isn't ST elevation, but it is a coronary occlusion requiring PCI. Okay, take a look at this one, scan it. I see some mild ST elevation in V3, V4, V5, but it is smiley face in nature. The QRS in V3 is down, the ST segment's up, so that also would be appropriately discordant. I see the notching fishhook pattern, very prominent in V5, so there's your Osborne wave telling me this is benign early repolarization. This is not STEMI. Okay, on this one, looking at it, we see some ST elevation in V1, V2, V3, some ST depression in V5, V6, some of the lateral leads, but my QRS is wide, my T waves are discordant, so I'm seeing some ST changes, but they're all going with the T wave, and they are not moving more than 25% the height of the QRS, so this is a normal ECG, or, well, it's not a normal ECG, it's LVH, but a normal LVH ECG, no STEMI present. And our last one here. So pause it if you need. We take a look at it. We see ST elevation in V2, V3, V4, V5, V6, even maybe a little bit out in the high lateral leads. But the ST elevation is diffuse. I see a Osborn wave present in V4, and my ST shape is smiley face or concave, indicating that this is one of the mimickers. If we were then to tell you that the patient had positional chest pain and a recent history of a viral illness, that would make this pericarditis, which is what it is. So